Thanks for listening to the FU Cancer Podcast. My name is Christina Rollins. I'm a dietitian, mom, and wife to a pretty awesome cancer survivor. We said FU to cancer nearly 25 years ago and are still going strong. I'm excited to share the FU Cancer movement, where we are a community of survivors, fighters, caregivers, and advocates, connecting our shared experiences, passion, and determination to live a holistic and well-balanced life. Stay tuned, because we've got a lot to talk about. Hey everyone, welcome back to the FU Cancer Podcast. Our topic for today is colon cancer screening with Dr. Seper Dezfoli. Dr. Dezfoli works in private practice and is the founder of Prestige GI in Long Beach, California. He specializes in gastroenterology, liver disease, and is a physician nutrition specialist. He has numerous publications and speaking engagements and has been named a rising star in Southern California's Super Doctors publication several years in a row, and most recently was recognized in the 2024 Best in California magazine. So, Doctor, thank you so much for carving time out of your schedule to chat with us today.
Great, of course. My pleasure. Thanks for having me.
So, colon cancer screening, not a test I think that many people necessarily look forward to, but it's important and we know it saves lives. So, who should undergo colon cancer screening?
So, yes, you're right. It is one of those tests that unfortunately is very dreaded, but unfortunately is also very much necessary. The truth of the matter is that colon cancer is one of the most prevalent cancers in America. It's the second most leading cause of cancer death in America. And so a lot of individuals can prevent that from happening simply by getting screened. And many individuals need to get screened. To answer your question as to who needs to get screened, this has a lot to do with risk factors and age. So as a gastroenterologist, what we do is we essentially categorize our patients into two groups: average risk and high risk. Based on which bucket they fall into, we know when colon cancer screening should be initiated. We also get guidance from our large gastroenterology associations that give us guidance based off of evidence and epidemiology and prevalence. So today we'll probably focus mostly on average risk patients because that is what applies to vast majority of the population. So for average risk, the guidelines actually used to say to start at age 50, but that really shifted in the last decade or so. So now average risk patients need to start getting screened for colon cancer in whichever modality fits their need at age 45. Average risk essentially means that your risk is no more than the average person. And so if you fall into that category, then 45 is when those individuals should get screened. What do we look for? So we look at age, we look at family history. That's what lets us know if the person is average risk or not. We look at personal history. Sometimes the personal history also lets us know if that individual needs to get screened because there are certain diseases, certain genetic diseases, and certain other cancers that give you risk as well too. So based on those kinds of factors is where we decide. But in general, if you're average risk, then at 45 is when they should start getting screening and they should look at the choices for how to get screened.
Hey, and what are the methods used to screen people for colon cancer?
So that's a great question. There's a lot of methods of doing it. I tell my patients that they almost have like a menu of options. So we divide them into different categories. When I'm talking to my patients, I really talk to them like it's a menu, like as if you have an appetizer section, an entree section, and a dessert section. And so what I tell patients is that you have one bucket, which is the stool-based testing. We have a second bucket, which is imaging. And we have a third bucket, which is colonoscopy. There's also a new way of getting tested, which is through blood, and I'm sure we're going to talk about that in general as well too. But right now, it basically falls into those three categories: stool-based, imaging, and colonoscopy. So when we talk about stool-based testing, there's really two ways of doing that. It's looking at a test called FIT, which essentially is submitting a stool sample and checking to see if there's any level of blood detected in that stool sample. The second stool-based test that is offered and is approved is called Cologuard. This is a stool DNA and blood test. What that means is that the patient submits their stool sample and it's checking for DNA markers that are linked to colon cancer as well as blood. So if they detect blood, it will be a positive result. If it detects DNA that's linked to colon cancer, it will also yield a positive result. So these two are the stool-based ways that we screen for colon cancer. In terms of imaging, we have what is popularized as the virtual colonoscopy. The formal name of that is a CT colonography. So this is a CT scan. So a CT scan is like a very powerful X-ray, so to speak. You go in a tube and they take pictures. And when they take these pictures, the radiologist and the technology is in a way where they can create almost a virtual map of a patient's colon. And the point of that is to see if they can visualize the colon cancer that that individual may have or any large polyps in the colon. So it's a non-invasive way to try to screen for colon cancer. The caveat here is that if the CT scan shows something that is suggestive of a cancer, then that patient would need to then move on to get a colonoscopy. So that's the imaging way of doing screening for colon cancer. And then the third bucket, as I mentioned, is colonoscopy. Colonoscopy is what I do. It's the bread and butter of a gastroenterologist procedures. And that is the direct way of looking for colon cancer and screening an individual. So if you think about the first two that we were talking about, the stool-based tests and the CT colonography, these are indirect ways of screening for colon cancer. And what I mean by indirect is that we're not really checking for cancer directly. We're checking for things that could mean a patient has cancer. So in the stool-based test, we're checking for blood and DNA. In the colonography, we're checking for abnormal imaging that may suggest someone has cancer. But with a colonoscopy, we're actually going right where the money is. We're using a camera to go inside the colon and travel through the colon to see if we can detect cancer with our own eyes. So what a colonoscopy is just that. We use a tube to go inside the colon and screen for the colon cancer. So those are really the three main ways that are approved right now with our guidelines to screen an individual for colon cancer who is average risk.
Now, when you're talking through those options with your patients, is there one test or method that is more accurate in detecting cancer versus others?
Yeah, so this question comes up a lot when my patients ask me that. So after I go through the menu, that's almost one of the main questions that someone asks me. They turn it on me and they say, well, which one is the most accurate? Because obviously that may be the one I want to do. And so when it comes to accuracy, what we look at is something called specificity and sensitivity. These are statistical terms that are applied to tests so we can understand how strong they are in detecting cancer and, more importantly, de finding a negative result in someone who doesn't have it. So
Mhm.
anytime a screening test is developed, we look at the specificity and sensitivity to understand, is this a good screening test? And look at that so-called accuracy that you're asking about. So when we look at the stool-based tests, the blood test, and the stool Cologuard, the sensitivity of a test is around 80%. What that means is that around 80% of the time, it will positively and accurately give a positive result in someone who actually has cancer. The specificity of these tests are around 90%. That means that it will accurately give a negative result when someone does not have cancer.
Mm.
So really that 80% is the one I look at when I talk to patients. And I say, listen, if you're going to do a stool-based test, around 80% of the time, it will accurately detect cancer in someone who actually has cancer. Now, when we look at a CT colonography, the CT colonography is a bit higher. It's also in the 80% ranges, but it's a bit higher than when it comes to the stool-based tests. When it comes to colonoscopy, you're getting the highest sensitivity and specificity. So it ranges around 95%, especially if someone has a good cleanse when it comes to the colonoscopy, which we'll talk about soon as well too. But that's where the numbers stand. So in terms of a general accuracy and strength, the colonoscopy is what would be considered as close to the gold standard as possible for detecting colon cancer. And that's what we really advocate for patients who are comfortable getting a colonoscopy.
Mhm. So aside from patient preference, as they've talked through their options with you and they understand the differences in the procedures, how does insurance come into play? Like, when does insurance dictate what my options really are, or really what will
Yeah.
be covered?
Yeah, that's an important question because patients want to get screened. They want to prevent disease, but at the same time, they're a lot of times they're worried. Am I going to get a huge bill? Is insurance the one that's really factoring into how we make our
Mhm.
decisions? So insurance comes into play in multiple different levels, not only financial, but also influencing the decision making.
Mhm.
Fortunately, right now, based off of regulations and laws that we have, preventative care is covered very well. And so insurance companies can't really dictate which modality a patient will use if they're eligible to use any of them.
Mhm.
So, for example, let's say I have patient A in front of me, and this is their first time coming to me and asking me, "Hey, doc, should I get a colonoscopy or should I get screened for colon cancer in the first place?" And let's say after I go through a series of questions, I understand that yes, this patient is average risk and they are eligible to choose any one of these menu options. I will go through those menu options through them, knowing that the insurance cannot dictate which one of those that patient can get. And the nice thing is that it really is patient centered. So after going through the benefits and risks of each one, I let the patient choose whichever one they want. Now, if they do a stool-based test, for example, and they feel most comfortable doing that, it will be covered, which is part of our regulations and our laws because that patient needs prevention. And so they will get the stool-based test that will be covered. If that stool-based test comes back positive, and that patient now necessitates a colonoscopy to understand why it's positive, that colonoscopy is not considered screening anymore. It is now called a diagnostic colonoscopy, which is not fully covered. So it will change the nuances of the payment structure. But again, will be covered though by the insurance. So the insurance will approve it, but the nuances of how it's paid for changes.
Okay. So walk us through a typical colonoscopy. If a person if they're at that point for either screening or for diagnostic care.
So it all starts first with meeting your physician. So that's with a consultation. Generally, patients will meet with a gastroenterologist like myself. They'll go through a series of questions to understand their family history, their personal history, and what their risk is. After they've settled on the fact that they want to proceed with a colonoscopy, then they go through a scheduling process. Typically, they get scheduled at a surgical center or a hospital, one of the two, where you have nurses, anesthesia, and other monitoring personnel before they actually go through with the colonoscopy. Patients will generally get a series of instructions to prepare for the colonoscopy. So those instructions will go with they'll go over it with the administrative staff or some personnel in the clinic. It'll tell them how to prepare for the colonoscopy. They'll go through that preparation process and then they will get to their colonoscopy day. On the colonoscopy day, they arrive to whichever surgical center or hospital setting that they're going to have their colonoscopy. They show up, they get prepared. The preparation generally means going through some paperwork, some registration. They will have an IV placed in their arm because that's how they'll get sedation or anesthesia. They'll meet their team. Generally, it will be a nurse, a gastroenterology tech, and of course, the physician. And then comes the big moment of getting the colonoscopy. So when the moment comes, they go into a private operating room. Patients are laying down. There's a certain position that they will lay down in, which is on the left side of their body, like in the fetal position. They will then get either conscious sedation or propofol anesthesia. So one way or another, the patient will be made comfortable. Once they are felt comfortable and they're not feeling any pain, and you know that the patient is sedated, then we start with the colonoscopy. That's where I come in. The colonoscopy itself entails taking a colonoscope, which is a camera. Looks like a long tube. The thickness of it is, I would say, probably about an inch. We insert it into the rectum and we simply travel through the colon. That distance is about 3 feet long, approximately, and we get a full visualization of the entire colon. The purpose of that is to screen for colon cancer and to check for other abnormalities such as polyps. That process takes about, I want to say, roughly anywhere between 15 minutes to upwards of 30, 35 minutes, depending on how clean a patient is how many findings there are, if there's polyps that need to be removed, and if you have to do any other interventions.
Mhm.
When the process is over, we remove the colonoscope, the camera, and then the patient is sent to the post-op area. In the post-op area, they're allowed to recover until they wake up and can speak, can eat and drink, and the colonoscopy is essentially over at that point. And then you wait, and generally, personnel such as myself will go and meet with the patient, talk to them about the results, let them know what we found, give them a report generally with pictures and writing that tells us what the report was, and that would be the end of that day. Patients will go home and they can relax. And generally, by the time that they get home, they feel just as well as they did when they arrived for the colonoscopy.
Yeah, I've had a few family members have colonoscopies relatively recently, including my husband. He turned 50. He had the recommendation, he had a colonoscopy. But the consistent thing I've heard is it wasn't the procedure that was the problem, it was the prep, right? I think everyone gets anxious about the prep. So, and you've
Yeah,
mentioned the word clean a couple of times. So, can you kind of
yeah.
elaborate on what that means?
Well, if you notice when you asked me what the process of a colonoscopy is, I kind of brushed over the prep part.
Right.
That was a strategy, but I can see you're going to get it out of me one way or another. But you're right. You're right. That's the part that most people, in retrospect, they find out that it's really the worst part. Some people are scared of a colonoscopy, and there really isn't anything to be scared of because you're asleep during that part of the procedure, and you really don't know what's going on, and you're getting a nice rest for about 15 to 35 minutes, but it's everything, it's what leads up to it. So we call it a bowel cleanse, or a bowel prep is another way of putting it. So if you think about it, the purpose of a colonoscopy is to screen for colon cancer. And we all know what the purpose of a colon is. The purpose of the colon is to absorb water, it produces a stool, and in which case we have bowel movements. But there's always a certain amount of stool that is in our bodies at any given point. Well, if there's stool inside your colon, that's really going to impair visualization. In other words, we're not really going to be able to see your colon as well as we want to see it. And if we're searching for abnormalities, you would want your doctor to be able to see everything as, as clear as day. So the purpose of the bowel prep is to evacuate and clean out, cleanse that colon as much as possible. In fact, we even have a scoring system for how clean a colon is when we do a colonoscopy. The maximum score is 9, and our goal as gastroenterologists is to really achieve a bowel prep score of 9 each and every time, because then we can have the highest yield when it comes to the colonoscopy and really be confident that we saw everything in every nook and cranny, so to speak. That bowel prep is essentially a really, really strong laxative. So if you've ever taken a laxative, if you have mild constipation here and there, imagine that on steroids. And it's a super strong either pills or drink that you take. And what it does is it induces diarrhea with the intention of eliminating and evacuating all the stool that's in the colon in that time period. To do the bowel prep, you will get really strict instructions from your physician and your office. Sometimes there are dietary restrictions. So, for example, in my practice, we have pretty strict dietary restrictions for a whole week leading up to the colonoscopy. There are certain foods that can really increase the amount of bulk and the amount of stool that somebody has in their colon. So we try to eliminate those. And there are also other foods that are harder to break down. There's always a running joke that when people have corn, they can see the corn the following day in their stool. And so those are things that we really want to eliminate in the diet leading up to a colonoscopy, because we don't want to see undigested food particles in the colon. So step one is occasionally having dietary restrictions. Step two is to go on a liquid diet. So generally for about 24 hours prior to your colonoscopy, patients will stay on a strict liquid diet. We call it a clear liquid diet. And there are certain protocols that every physician has, and we'll explain to the patient. The purpose of being on a liquid diet is so that the body doesn't produce any new stool in that one day leading up to the colonoscopy, so that it can increase the chance of a clean bowel.
Mhm.
And ultimately, you will take a strong laxative that will induce that diarrhea that I talked about. And yes, that could be the quote unquote worst part of a colonoscopy. But the way I describe it to patients who don't know what to prepare for is I say, Think about those times when you've randomly gotten food poisoning. You go on a cruise, you go on travels, and unexpectedly you'll eat something or get, exposed to something, and you get, Montezuma's revenge or traveler's diarrhea. It really is the same kind of concept where you have several hours of diarrhea. But the exception here is that it's under your watch, under your control, and in the privacy of your own home. So, unlike those scenarios where you're traveling and unexpectedly you get diarrhea and you really have to figure out how to kind of live your life for those, 8 to 12 hours, here you know what's to come. You have your own bathroom, you have your own kind of structure and privacy. And so, that's exactly kind of what it is, and you just kind of get through it, and you to prepare for your colonoscopy. And it's an unnecessary evil, but the nice thing is that with modern medicine, they've created different formulations. As I alluded to, there's pills now that people can take. Well, the number of pills can be somewhat higher than normal, but it's pills mixed with water. There are different powders that people can drink that are mixed with water. Now they have flavor packs that have been mixed in. So there's different options. So my recommendation uh, is to talk to your doctor, ask them if they have different choices, pick your poison, the one that you think you're going to tolerate the most, and just get through it, and know that what you're doing is really going to improve the visualization of your colonoscopy. So it's really the part that's going to improve that part of your healthcare.
So once you've had, the colonoscopy or an effective screening test performed, what happens if an abnormality is identified?
Great question. So, of course, the primary purpose of a colonoscopy or screening for colon cancer is to check for colon cancer. So, let's talk about that abnormality first. So, if we do a colonoscopy and we identify colon cancer, then first thing we do is take a picture and to document it. Number two is we take a biopsy. We can take biopsies at the time of the colonoscopy. We have different tools that we can pass through the camera and pluck off a little bit of tissue to send to the laboratory. That's really important because even though we can see the cancer and we know someone has it, we really need to have that pathology diagnosis that our oncology colleagues are going to need to understand what type of cancer it is, what stage the cancer it is, and how to treat that patient. So we take biopsies at that time. Once the colonoscopy is over and we've taken our biopsies and our pictures, then we generally refer those patients to a couple of doctors. The first would be an oncologist, which is a cancer doctor. The second would be possibly a surgeon in case that patient will need surgery as part of their treatment plan. And the third one sometimes would be a radiologist or a radiology department. And that comes into play when someone needs to find out what stage of cancer they have. So we generally send patients for PET scans and CT scans, and that helps also our surgeons and our oncology colleagues. So as far as cancer, that's how we would manage it at the time of the colonoscopy. The other thing that we do colonoscopies for is prevention. We prevent colon cancer or decrease someone's risk of colon cancer by identifying polyps. Polyps are small growths that potentially could turn into cancer. What I tell my patients is that not all polyps will turn into cancer, but all cancers started as a polyp. So when we see a polyp in the colon, we always will try to remove it at the time of the colonoscopy because we don't know if this is the type of polyp that could potentially turn into cancer. And so while we're there, we might as well remove it to decrease that individual's chance of turning into cancer. So that would be the second type of abnormality that could be found during a colonoscopy. And to answer your question, we try our best to remove those polyps at the same time. Most polyps can be removed at the same time. There are a few exceptions of polyps that are larger or flat or have unusual structures, and those may not be amenable to be removed at that time, in which case we would biopsy them, tag them with some coloring, and then refer those patients to get either surgery or a repeat colonoscopy by a advanced proceduralist to remove them. If other abnormalities are found incidentally, such as inflammation or other kinds of abnormalities that are seen not outside of cancer and polyps, generally those are documented by taking pictures and biopsies are taken at the same time.
So, just a few minutes left in our episode, but are there any new tests or devices that you know of that are under development that may improve our ability to detect colon cancer in the future?
Yeah, so we're always trying to advance ways. Right now we have found that while there are so many ways to screen people for colon cancer, an unfortunate statistic is that only about 30% of those who are in the group that should be screened who are actually getting screened. So that's 1 in 3 people who are actually getting screened. So that's pretty low. And that's one of the reasons why we want to send the message out. And so with that, there's also always technology and research being done to find new ways of screening patients so that patients can have more choices with the hope that we can make it easier for patients to get screened and increase that percentage. The most recent test that was FDA approved is a blood type test. This blood test is looking for DNA that is roaming in the circulation, so in your veins, in the blood, that is related and linked to colon cancer. So much like the stool test that I was explaining, where we can detect DNA from colon cancer in somebody's stool, this test is doing a similar concept, but in the blood. So basically, you just draw your blood and you can find out if you potentially could have colon cancer. Um, for that, again, the sensitivity is a bit lower than a colonoscopy. It's
Mhm.
around 80% as well, so similar to the stool-based test. And again, that means that around 80% of the time, it will accurately detect cancer in someone who actually has cancer. And around 95% of the time, it will yield a negative result in someone who actually does not have cancer. So it's on par with the stool-based tests. And something to keep in mind with the blood-based test is that if you get a positive result, then it would then necessitate a colonoscopy to check for cancer. This blood test is FDA approved. It actually just recently got FDA approved in 2024. However, it has not still made its place in our guidelines. So our national societies, our gastroenterology societies have not really incorporated this test or given a formal recommendation as to who should do it, how often they should do it, etc. But it is out there, it's FDA approved, and people are eligible to use it if they want to do that and are not interested in getting a colonoscopy.
Great. Well, thank you so much for sharing your expertise with us on this important topic. I hope our listeners are motivated and feel a little bit more comfortable now about colon cancer screening.
Yes, great. Well, thank you again for having me, and it was a pleasure.
And listeners, access more great content related to cancer care on our website, fucancer.health. And be sure to like and follow us on Spotify, YouTube, or wherever you access your favorite content. Until next time, I'm Christina Rollins. Thanks for listening.